Awesome.
Perfect. Let me just share screen. You guys can see this all well, I assume? It appears normally?
Yes, it does.
All right. So I wanted to talk today, instead of about sort of TAVR or mitral or something that's really, I wanted to touch on a subject that's probably more applicable to really everybody on this. And that's the management of coronary disease both during, and then after TAVR. I think it's fair to say that if you haven't cathed a patient who's going for a TAVR, or if you haven't cathed a patient after one, you will shortly. So here are my disclosures. So for the outline of this, I'm going to discuss the role of PCI prior to TAVR, talk a little bit, because it's interesting, about the risks of coronary obstruction during TAVR, and then spend a fair amount of time talking about an overview of coronary cannulation and PCI post-TAVR, how to do it, some things that may be beneficial, and then finish by talking a little bit about some concerns about the coronaries for valve, and save a little bit of time at end for discussion. So one of the questions is, what is the prevalence of coronary disease in patients undergoing transcatheter aortic valve replacement? So if we look at that, what we see is it's variable. Whether we look at high risk patients where the prevalence of coronary disease is up to 75%, or whether we look at low risk patients where it's down to around 15%. Needless to say, the prevalence of coronary disease quite high, somewhere between 15 and 75% in patients undergoing transcatheter aortic valve replacement. So I'm going to give 4 cases here, and then maybe call on some people to give what they think. So the first case is a 78-year-old male with severe aortic stenosis, progressive heart failure, and angina, prior CABG. His cath shows a patent lima to LAD, patent vein graft to a diag, and a large caliber RCA filling via left to right collaterals. It's unchanged since 4 years ago. Second case is a 72-year-old female with end-stage renal disease on dialysis, severe distal left main disease, prox LAD and mid-RCA, EF of 30%, has a lobectomy and for lung cancer and recurrent heart failure. The third one's a 76-year-old male with 80% distal left main, 90% ostial RCA, normal LV function, severe AS. And the last one's an 82-year-old male with an 80% prox LAD, metastatic prostate cancer, bad renal failure, admitted with an aspiration pneumonia and severe aortic stenosis. Before we get to them, I always think it's helpful to look at the guidelines. So here are the guidelines for coronary disease before TAVR. My screen hasn't frozen. I'm just showing you what the guidelines are. In essence, there are none. We do have guidelines for coronary disease before surgical aortic valve replacement, and that is for patients who are over the age of 40, and there's a high likelihood that they get a coronary angiogram or a CT or stress test. And if they have coronary disease with a greater than 70% diameter stenosis of a major coronary artery, or greater than 50% of the left main, that at the time of their aortic valve replacement or whatever valve they're having done, that they also have bypass. I think it's important to note that the level of evidence for this is level C. There have never been any good studies done looking at it. And, that's one of the challenges here. We still revascularize, we see that mid-LAD and that right lesion, and we say do a CABG in a piece, or do a CABG in an AVR in that patient. It's really not, it's never been addressed in any randomized studies, coronary revascularization, when it's asymptomatic in patients undergoing a valve operation. So we do it, but I think it's important that we recognize why we do it, and we do it not based on a single randomized study that's ever been done. So what about revascularization prior to transcatheter aortic valve replacement? So there's been a number of studies that have been done looking at this. And what has been shown is that it may be safe to waive variable degrees of calcification of coronary disease without intervention, and instead pursue the treatment of the aortic valve disease, provided, as they say, a rational and pragmatic approach to the coronary disease by the heart team. So as opposed to surgical stuff where we say, fix it, even though we don't have any randomized or really good data at all, the data, again, this isn't randomized data from TAVR, would suggest that actually a fair amount of it can be left behind. And I think those of you who have been here since the sort of beginnings of TAVR, we used to stent, we used to do what sort of the surgical guidelines were and revascularize even if it was asymptomatic coronary disease. And we actually had a fair number of complications in those PCIs. And we've changed the practice a fair amount now. So let's go back to these patients and I'll see if I can pick Rob, why don't you, who are the fellows who are on? We can pick on them and see what they want to do for these patients. I can't see who they are.
I can look them up for you.
I see Natalia's here, so I'll start there. So Natalia, case one.
I knew one.
Can you
I was gonna volunteer. So.
Okay, good.
Yeah. Okay. I think this person is elderly and they've had one sternotomy so far. So second sternotomy would be a big deal. The fact that they have this CT of the RCA, it's chronic and unchanged, and they have no angina. I just give this person a TAVR and no further revascularization. The rest is patent, like Lima to LAD and the SVG to DIAC.
All right.
So I just do a TAVR.
Cynthia, I see you on as well. Case two.
All right, so 72-year-old female with end-stage renal disease on dialysis. So that would make her a higher risk for surgery. So she's got severe left main disease, proximal LAD, and also mid-right. So her EF is 30%, so that would also make her higher risk for surgery. Severe AS, lobectomy with lung cancer and heart failure. Oh boy, she's a little bit more complex. So she's got low flow, low gradient AS. I mean, I would say probably we'd have to discuss the left main prox LAD at least, so revascularization. I think she'd probably be higher risk for surgery, and maybe like TAVR and PCI would be like an approach for her.
All right, Russell Rosenberg, case three.
76-year-old, 80% distal left main, osteal RCA, normal EF, severe AS. Seems like a reasonable candidate for SAVR cabbage.
All right, and how about Phil Chu?
82-year-old, known LAD, props lesion, metastatic prostate cancer. Yeah, these pretty bad kidney CKD, aspiration pneumonia, severe AS. I would do NIDAR. It sounds like more of a palliative care approach.
Sorry, I missed what you said, Phil.
I said this gentleman has a lot of comorbidities. He has a pretty bad prognosis with metastatic prostate cancer. This is someone I would seriously consider for palliative care.
Yes, thank you. All right, so here, these are all real cases, things. Sorry, let me click there. So TAVR alone, I agree. So case two, I think, is an interesting one. So I would caution against doing TAVR up front with that. That's a patient who actually ended up having a BAV and then the complex PCI. I think you want to revascularize that coronary disease first. It's pretty severe there. And she's symptomatic from it. So that's what we did for this patient. Case three, I definitely agree, needs a cabbage and a surgical aortic valve. In case four, we certainly see a lot more of those, needs palliative care. At least those are what we chose for these patients. So I want to move on to sort of PCI pre-TAVR, and sort of, I think we can summarize that, if it's very high grade disease or we think it's causing the symptoms, you can fix it. If you don't think it's causing the symptoms, you can often leave it behind. And then talk a little bit about sort of PCI during TAVR. So this is a 79-year-old woman who's undergoing a transcatheter valve. You can see her body habitus there, that sort of classic pear shape, as it were. And the plan in this case is for a 23-millimeter subclavian approach for a SAPIEN 3 valve. So a couple of things to note in her. So when we're looking at these patients, one of the things that we look at is the sinus of Valsalva. So the sinus of Valsalva there is measured in this picture here, and here sort of looking at it. And what you can appreciate is that in most patients, as the ascending aorta, as you come down the ascending aorta, your sinus bows out some. This patient has almost what we would call sort of a stovepipe sinus, meaning that there isn't really much definition of the sinus. There's a little definition here. On this side, it's really just straight. And so when we measure that, it measures out to about 25 to 26 millimeters in all of the diameters. The other thing that you'll appreciate here is the height of the left main coronary. So the height of the left main coronary is about 12.5 millimeters. If we look at the size down at the annulus, and that's how we size the aortic valve, we'll see that we measure here a perimeter of 67.4 or an area of 350. And we then use either this area or this perimeter to determine the size of the valve we're going to put in. So the size of the valve that we'll put in for these patients is either going to be a 23 millimeter SAPIEN 3 valve or a 26 millimeter core valve or Evolut R. Now, one of the things that's important to note, a difference is between sort of the guidelines here for the SAPIEN valves versus the Evolut valves is you'll see when it gives you what you need to be looking at. For Evolut, it talks about the size of your sinus of Valsalva, and it recommends that you have a sinus of Valsalva that averages greater than 27 millimeters. The reason for that is that when we're putting this valve in, we're going to take these native leaflets and we're going to push them off to the side. And if there's room in the sinus of Valsalva for those leaflets to sit, then you should maintain your coronary perfusion. But if there's not room in the sinus for those for these valve leaflets to fit, you may obstruct the coronary. So this is actually a patient who, based off of the IFU, would not have appropriate sinuses for a core valve. I hope that makes sense to folks. So here's the procedure. You guys have seen plenty of TAVRs before. Here's the valve being implanted. We just wanted to implant it just a little bit deeper because we knew the coronary heights were a little bit lower. And so the valve's implanted slightly deeper there. And there's a shot there on the end and everything looks good, right? So the nice, you can see nice flow, no aortic insufficiency, nice flow down the left main, nice flow down the right coronary artery. The patient's given protamine, we start closing up the groin, and 20 minutes after implant, the patient develops severe hypotension. So this is sort of one of the most feared things in transcatheter valve, similar to how it is in a PCI. When your patient post-PCI develops severe hypotension, after you finish the case, you start to worry a lot. And the differential diagnosis is fairly similar for the two. Bleeding's always at the top, followed quickly by pericardial effusion. In this case, certainly as opposed to coronary perforation or coronary rupture, we worry about potential rupture of the aortic annulus, and that's just causing sort of similar to a coronary, but a little bit more dramatic. When that balloon goes up, you actually are rupturing the annulus where you're putting it. Protamine reactions can occur. We give that after the vast majority of our TAVRs, and we can see that. Coronary obstruction, we talked a little bit about that. So actually having one of these native leaflets obstruct the left main. Dysfunction of the valve that we've put in, you can sort of think of that as akin to acute stent closure in a PCI. Something's wrong with the valve, it's not opening, a leaflet was frozen, the valve's moved around somewhere. Unfortunately, what we have a fair amount of the time is the anesthesia resident having flushed something through a long line, which can obviously happen. And I guess the question is, what do we do next? And maybe I'll pick on somebody else. I think, was Stacy Stephanie on there?
Yep.
All right, what do we do next?
So we can just get a quick stat echo to see if
Perfect.
there's any effusion, or look at the valves as well. The T
Yes.
people or the echo people are already there.
Yep, so I think similar to in the cath lab, the first thing to do is to get an echo, right? An echo can tell you a vast majority here. So this is a patient who had a normal function before, and I think we can all appreciate on this image, right? We have hypokinesis that was not present before. Nice moving here of the septum and hypokinesis here. So this, right? No pericardial effusion. We don't look like we're bleeding. Our IVC was okay. We haven't ruptured the annulus, probably not a protamine reaction. The valve's working okay, but all of a sudden we have new regional wall motion abnormalities. And so we bring a catheter up here, and it's a little bit hard to appreciate here, but if we pause this, what you can appreciate outside the valve frame is this echolucency, okay? And as it comes up here, it really ends up sort of tapering the left main here. So what this is this is the native leaflet that's been pushed up, okay, and is almost occluding the left main, right? It's not fully occluding the left main. Obviously, if it was fully occluding the left main, it wouldn't be a blood pressure of sort of 80 or 90 that we're having to give a fair amount of support for. It would be much, much more dramatic than this. But this is a valve here, the native valve that's been pushed to the side by the transcatheter valve and is partially occluding the left main. So coronary obstruction and after transcatheter aortic valve replacement. So plenty has been written about it. A lot of things have been sort of researched and tried to understand in a retrospective analysis, looking at why it happens. So it tends to occur in less than a 1% of patients, about 0.5%. Tends to occur much more frequently in women than in men, and is a very high 30-day mortality. As we've talked about here, it's important to recognize that this isn't the valve, the new valve that alone is obstructing the coronary. What this is one of the big differences between a TAVR and a surgical valve is that we haven't taken out the old valve that was there. And this old valve, which has been pushed to the side, is now blocking part or the whole coronary. About 50% of them are complete occlusions, and about 50% of them are partial occlusions, and it tends to impact the left main more than the right coronary artery. Some of the characteristics, so anatomic characteristics that can predict it, would include a small sinus of Valsalva, less than 30 millimeters, or low coronary heights. If we look at when it tends to occur more, you'll see here it tends to occur more with smaller valve sizes, probably because those are being put in smaller anatomy. It has a significantly increased frequency if we're doing a valve and valve procedure, either a valve and valve surgical valve or a valve and valve transcatheter valve. And here, the data here says it occurs a lot more with balloon expanding sapien valves than with self-expanding evolute valves. I think the reason for that is that the evolute valves actually carry a warning sign about the size of your sinus of Valsalva, whereas the balloon expandable valves don't. There's nothing really different about the valves in terms of how they're going to interact with the native leaflets. They're both going to push them out to the side. So that's really the etiology for it there. So why did it occur in this patient? Again, we have sinuses that are quite small, and we talked about the STJ that was there for the valve size that we were putting in. So, an overview of coronary obstruction management in setting of transcatheter valve. The first thing is that you got to make sure all your rooms have PCI equipment easily accessible. We're up in the Zigo room today. We can't have the staff running down to go get guides and wires and other things. It's important, if it's not in the room, to at least have it readily available, some sort of cardiopulmonary support, whether it's an Impella or ECMO or something else, that if the patient really crashes with a complete obstruction, you have that ready to go. Now, there are some ways that we can talk about protecting this. So if you have no option, you have no surgical option, there are actually cases that we will do where we'll actually put a stent in the coronary artery. We'll actually put it down sort of into the LAD. We'll deploy the valve, and then we'll bring the stent back, and we'll actually snorkel the stent, often quite a few millimeters, sometimes as much as 5, 10, 15 millimeters into the aorta after we've put that in, to allow flow down there. So in very high risk cases where you don't have other options, that's one of them. When you think you're at high risk for potentially having coronary obstruction, I think it's always beneficial to consider using general anesthesia and the TEE. It gives you immediate feedback about what's going on. I'm going to skip over this role for angiography. And I think it's also important to analyze all your patients. If you have really low coronaries, one of the questions is, if you have an intermediate risk patient, might that patient do better with a SAVR than a transcatheter valve? Again, it's within the randomized studies, while TAVR patients recovered quicker, et cetera, by 6 months and certainly by a year, the surgical patients were doing as well as the TAVR patients were. And patients who had anatomy like this would have been excluded from those studies. So I don't think all intermediate and sometimes not even all high-risk patients necessarily need a TAVR. I think just like we look at surgical risks, porcelain aortas, things like that, when we see patients in our valve clinic, we're also looking at their TAVR risks, and one of them is risk of coronary obstruction. We talked a little bit about, is there a difference between self-expanding and balloon expandable valves? I will say we have had some cases with self-expanding valves, and one of the nice things about them is because you can partially deploy them, you can partially deploy the valve, you can look to see if you're obstructing the coronary, and if you're not, you can then fully release the valve. So if we go back to the patient, what you'll actually see is as soon as we got the guide in, you can appreciate on this first shot here with the guide and the wire that the flow actually improves significantly, right? You don't see that stenosis right there of the left main. And the reason for that is that with the guide there, the guide's actually pushing that leaflet out of the way. So the patient did much better even with just the guide and the wire there, but obviously leaving the guide and the wire is not the long-term solution. So we went ahead, we stented this with a 4/12 drug-eluting stent, hanging it back into the aorta just a little bit. And here you can appreciate the final shot. And so I think you can see here the significant difference of how the ostium of that coronary is now nice and wide open, whereas previously it had been significantly compromised. This patient was fortunate, did quite well, but was eventually discharged on post-op day 3. So that's coronary interventions pre-TAVR and coronary interventions during the TAVR. So let's talk a little bit about coronary access after the TAVR. This is certainly something that we are seeing more frequently. It'll probably be as frequent, if not more frequent than coronary access after a surgical aortic valve, given where the numbers are across the United States. Just so that everyone's aware, in 2018, we crossed that threshold of within the US doing more transcatheter valves than surgical valves. And those numbers have continued to go sort of not quite in opposite directions, surgery declining slowly, but still a rapid rise in the number of transcatheter aortic valves.
Dr. Forrest, quick question, like in the previous, this is Amar, the previous case, like the obstruction was external to the left main, right? So it is from the native wall.
Yeah, so it's right up again, but it's right up against the ostium of the left main, correct?
Okay, I know if you place a stent, like it's within the lumen of left main, what happens to the native wall? Like, would it
to the valve? It's to the native valve or to the transcatheter valve?
To native wall that was obstructing the lumen.
Right. So it just gets, so you that's why you extend the stent a little bit into the aorta, and the stent itself just holds the valve down. So it keeps it out of the way.
So you keep part of the stent like outside, a little bit outside. Okay.
Yeah. So when we're deploying it, as you can appreciate, I'll play this one here. When we're deploying the stent, you can appreciate that we bring the stent back here so that it's not like we were doing it as we would a normal PCI, where you're trying to sort of end right at the ostium of the left main. We're sort of splitting the difference here. We're having about, 6 or 7 millimeters into the left main and about 5 or 6 millimeters outside of the left main to hold the native valve down.
Okay. Thanks. That makes sense.
So coronary access after a TAVR. So data has shown that it's technically feasible and is generally reported as being positive. So you can see here success rate somewhere between 90 and in some cases 100%. That being said, coronary access after TAVR, especially when the frame of the TAVR extends above the coronary ostia, is often not easy and often requires manipulations, different guides, different catheters. So while it can be done, it's definitely not as easy as doing it in natives. So there's been a number of studies that have been done. One of them was the ReAccess study. So in this study, 300 patients had coronary angiography performed before and after their transcatheter aortic valve. A little over 100 of them had an Evolute, which is a supraannular, it's like the core valve. 96 of them had a SAPIEN 3. Those are really the only 2 valves that we use here. The Accurate Neo was just approved by the FDA last month. A lot of this study was done in Europe, so they had a fair number of Accurate Neo valves and a handful of Portico valves, which is now off the market. So here what you'll see is that obviously cannulation before the TAVR was successful in all of the patients. And you can see that after the TAVR, you were able to do selective cannulations in the majority of them, certainly for the left. The right, about 60, little over 60%, you were able to do selective. Semi-selective, you were able to do in, between the semi-selective and selective, and about 95, 96% of patients. But in about 4% of patients, they weren't able to successfully recannulize either selectively or semi-selectively the coronaries. It's important to note that of the 23 cases where the coronaries cannot be reaccessed, 22 of them were using the Evolut R or the Evolut Pro valve. So the valve that has its frame that comes above the coronaries. And so when we look at the Evolut valve, if you pretend right now that you're the left main, that you're sitting in the left main and you're looking back out to the left main ostium and then looking back out into the aorta, what you will see if the valve is positioned correctly, meaning anatomically aligned with the coronary ostium, is that this is your sewing here, right? If your valve is implanted at a good place, I shouldn't really say low implant, but at a normal implant, you should be looking out and seeing something like this. But if the valve's implanted high, you may actually be looking out and seeing the valve right there. And in fact, it's a supraannular valve. So this is metal with tissue right behind it. So you're not looking out at open struts. You're actually looking out, in essence, at closed struts. Now, remember, the sinus of Valsalva is between the coronary ostium and this valve frame. So there's space there, okay? It's not that this is directly against the ostium. There's space there. But when you're talking about trying to re-engage the coronaries, out the coronary from above, and that can be quite difficult. The other thing is that if this valve that you've put in is not anatomically aligned correctly, this is actually how the valve looks at the commissure. So it has extraordinarily high commissures. This is part of its supraannular structure here. And so if the valve has not been aligned when it's been implanted, and now you're looking out from the coronary ostia, you are going to have almost inevitably be looking out at frame with material behind it. And you're now going to have to come from up here somewhere else to try to engage this coronary artery that's down there. So that certainly is why in a number of cases, now we try to line these up anatomically when they're going in, and there are some tips and tricks for that. But the truth of the matter is, while we try to do that, I think we are in the minority. It's not something that's that easy to do. And so it's something where you may, if patients have been done at other centers, or if we haven't been successful here, be facing an issue where here's your coronary here that you're trying to engage, and in front of it is all of this material. So you're actually going to have to come sort of through a strut here or through a strut here and down to the coronary to engage it, which is often why you end up needing sort of non-selective engagement for these valves. So recent history at Yale, this is a little bit old. I put this together a couple of months ago. But I think in about April or May of this year, we had actually had 3 cases in the prior 3 months. 2 of them had been STEMIs and TAVR patients. One was 7 days out from the TAVR, presented back with HIT, PE, and a coronary thrombus in the LAD. One was 3.5 years out from his TAVR and presented with mid-RCA disease. And one was an elective PCI for a TAVR, again, about 3 years out, this patient came in with angina. This patient actually came in, I should say, the RCA patient came in with a STEMI. It wasn't elective. It just 3.5 years out ruptured a plaque in the mid-RCA. Should note that all of the patients had an Evolut R or an Evolut Pro valve in place. I may have just heard about those because those are harder, and there may have been more patients that came in maybe with SAPIEN valves, but I heard about all 3 of these cases. So I wanted to finish the talk just talking about some tips and tricks for reaccessing coronary, specifically in Evolut R and Evolut Pro valves. So the first thing I would say is if they have that, you should see it in the chart. I'd recommend femoral access for these patients. And I'd also recommend using JL and JR catheters, not just for the diagnostic cases, but actually also for the interventional cases. So again, we're not used to using JL guides very often, but this is one of the settings where I do use JL guides. When you're using your guide, because the valve itself sort of narrows the aorta some, I often will start by downsizing my guide catheter by about 0.5 centimeters. So if I was going to use a JL4, I might use a JL3.5. The other thing to think about is we're often used to, especially when we engage our right coronary arteries, but even when we engage our left coronaries, is starting low and pulling up and clocking, et cetera. You can't do that in this case. You have valve and you have frame down there. So you have to really aim for the waist in the frame and either be coaxial with the coronary or at times actually engage from above the coronary. Another important thing in all of these cases is that I would recommend prior to trying to deliver anything down that you have a guide extension in, either a guide liner or a telescope or whichever guide extension you're comfortable with. And I'll talk a little bit at the end about when you're taking the wire out, you actually want to remove the guide catheter over the wire. So we talked a little bit about this, use a JL or a JR catheter. Here's a JL. And as opposed to an EBU, which is going to come down and back up here, the JL is really going to more address this from above. And what you'll often find is as you try to manipulate this, you'll come through this stent strut here, then you'll come through this one, and eventually you'll come through the proper one. Now, sometimes the proper one puts you sort of down here or up here, so it's more semi-selective. But you'll find even with semi-selective as you're there, it's good enough. You can get a wire down and then you can get a guide extension catheter. We talked about downsizing a little bit. So if you're going to use a 3.5 instead of a 4, etc. Again, you have to think about where this valve is. You're not going to be able to start down here and come back up. This is going to be your coronary access target zone when you're looking at the evolute valves. Down here, there's an outer wrap on it, and so you're not going to be able to get through the stent frame down in this area. This is where you have open cells to get through the frame of your evolute valve. Again, it's recommended the coronary access zone is the open cells between the narrowest portion of the TAVR frame. The smallest cell can actually fit a 10 French catheter, so you shouldn't have problems getting your catheters through there. If coronary engagement is unsuccessful, consider the following. Often, sometimes if we can't get with a diagnostic, we'll change to a guide catheter. We'll target an adjacent cell, or we'll attempt partial selection and then engaging the coronary with a wire. Again, we often will find that we're able to sort of park the guide here or here, engage it with a wire, and then use a guide liner or a telescope to get down. And the last thing that I'll say is that after you've finished your PCI, what we normally do is pull our wire, right, and then counter your catheter to come out. Well, if you think about the frames of this, it's sort of a V. And if you pull this catheter back, there have been times where the catheter itself has gotten wedged up in the frame. So to prevent that, what's recommended is after your final shot, bring your catheter back over your wire like this, and then remove your wire. I hope that makes sense to everyone. This prevents you from getting your catheter stuck in your valve frame and wedging it up in the V of these cells here. If you don't do this, there have been cases where it's been wedged there and they've been unable to get it out. Like anytime you're removing a guiding catheter, slightly rotate it counterclockwise or clockwise when you're doing it. So here's a nice case of a patient with an RCA infarct. I think we actually did this here. And you can appreciate, right, we're not able to selectively engage the right coronary artery. We're sort of a little bit away from it, can't selectively engage it. But from where we are, we're able to wire it down. In this case, we used an export catheter. And then after wiring it down, we used a guide extension. And after the guide extension, we were able to bring it actually brought our guide all the way in. We're able to stent this mid RCA and it was okay. So don't be afraid of starting from this spot here. This is where you often will have to start from, and you should be able to wire it sort of offshore and get yourself there, then bring a guide extension in, and then over that guide extension or over those balloons, you often will be able to get more support. You can appreciate here, catheters like an AL or an AR are just not going to work very well. For the right coronary, you really need a JR. Sometimes a no torque is helpful for your diagnostic cases. I'm going to finish just talking a little bit about valve-in-valve concerns.
John, can I ask a question?
Yeah, go ahead.
Do you have any concerns about pre-existing osteal stents, especially like right coronary location, et cetera, and how that goes into your TAVR planning?
Yeah, you know, we did a case the other day of that where there was an RCA osteal stent that was hanging out about 6.4 millimeters into the aorta. And so we actually, in order to maintain that, we actually had to wire the coronary before we did the TAVR. We did the TAVR, which sort of pushed up against the frame of the osteal stent. And then we inflated a balloon, which we had in place inside the coronary ostia extending out. It actually, not surprisingly, when we had wired the coronary, I mean, there was so much stent hanging out, we hadn't wired it directly through the end of the stent. We had wired it sort of from below through some stent struts. So with the stent itself fractured where we had come through, but actually, you know, by doing that at the end of the case, we were able to take a diagnostic catheter up and very easily engage the artery. So, but to your point there, what I would recommend and what is now recommended is that if you're doing a PCI on a patient and doing an osteal lesion, and you know that patient is planned to go for a TAVR, I would really recommend using an osteal flash balloon. If you're not familiar with an osteal flash, it's sort of a two-step balloon where there's the distal end of it is sized sort of normally 3.0, 3.5, 4.0, but then the proximal part of it is a really large balloon meant to flare that end of the stent outside the ostium. So there's been a fair amount written recently about using osteal flash for these cases. And if you have a case that you know is going to need a TAVR afterwards, find somebody who knows how to use an osteal flash balloon. I'm happy to show people how to use it. I think it will make not only things for the TAVR better, but also coronary reaccess a lot better. Before I move on, any other questions? All right, I'll keep going then. So the valve-in-valve concern, I think the last thing I'll talk a little bit about is regardless of which valve you're using, if you put a valve inside a transcatheter valve, what you're really creating with that first valve is a covered stent graft. Whereas we would have before tried to engage the coronaries through these open struts, when we push these leaflets of this valve up, we create a covered stent graft. And as a result, it can be impossible at times to get through. The same thing with the evolute. In fact, the evolute is even worse because now because it's a supraannular valve, whereas here you'd be able to come through any of these struts. Now you've created a stent graft and you can only come through there. Okay, so it can be almost impossible. You have a significantly higher risk of coronary obstruction and can be almost impossible to re-engage the coronaries if you've done a TAVR inside a TAVR, especially with an evolute valve. So there are some tips and tricks that can be done for that. One of them is we talked about before is snorkeling stents in. I don't have an example of that, but I'm talking just briefly here about the BASILICA procedure. So this stands for bioprosthetic scallop intentional laceration to prevent coronary artery obstruction. Nice long name, BASILICA sounds better. If you haven't seen this, it's pretty interesting the way that it works. So the idea of the BASILICA procedure is that instead of creating this stent graft here with the native leaflets being pushed out, that you're going to cut this aortic leaflet here, so that when you then put in your transcatheter valve, either your sapien valve or your evolute valve, you actually have created a V here so that blood can flow down and so that you can better re-engage your coronaries. So how do you do this? So this is the BASILICA procedure sort of in brief. This is similar to some of the things that we do when we're electrifying wires and doing transcaval procedures. In fact, the people who came up with this were the same who came up with a transcaval procedure. What you will do is you'll take two guiding catheters. One goes across the valve and into the LV here where you open up a snare, and the other one comes down and sits right here at the base of the aortic valve leaflet, right at the ostium of the left main. You then take a Stato wire or a similarly stiff wire that you can poke through. You perforate through the leaflet here. You electrify it as you perforate through the leaflet here, and you snare your wire. You snare it and pull it out. You then make a rail here so that you have we actually bend the wire in a V like this, so that you have a V here. You have your two guides here. You then electrify the outside of the wire by heating it up with a Bovie catheter, which electrifies the whole thing. And doing that for a few short seconds, you then pull these two catheters up together, which creates a slit there in the native valve. Once that slit is there, you can then put in your transcatheter valve and go from there. Again, there's the sort of stages of the BASILICA. You snare it, you transverse the leaflet, you have this V shape in it, you lacerate the leaflet, and you perform the transcatheter valve. Again, I show that just because it's sort of some of the interesting things that we're doing these days to try to allow for better coronary access. I'll finish here just talking about some interesting things that are going on. We're now developing CT modeling for looking at coronary obstruction, both with the first transcatheter valve and with the second one. There's some very interesting models that are out there. We now have software where we can sort of take a valve and insert it into our CT scan, play with the native leaflets, and do some with in essence, computer processing using lots of data points from how it's come, try to predict how this valve is going to interact with the native leaflets and what's going to happen to the coronaries. It can be applied to both TAVR and valve procedures. So take-home points here. First, the decision of PCI pre-TAVR should be irrational and pragmatic, driven by the heart team, and recognize that there are a lot of cases where we used to stent, but we no longer stent. Coronary obstruction during TAVR is rare, but be prepared. The risks include small sinus of Valsalva, low coronary heights, and especially valve. Engaging coronaries through transcatheter valves, especially the evolute frame, requires modifications to your regular routine for coronary angiography. If the commissures of the native valve and TAVR are not aligned, this may require non-selective engagement, offshore wiring, and the use of guide extensions. And valve procedures very much increase the risk of acute coronary obstruction due to the creation of a stent graft, and what can also make coronary re-engagement especially more difficult for supraannular valves. And I think this is something that we consider more and more when taking care of our younger patients. So I will finish up there. I know we got a few minutes for questions.
So John, going back to the coronary access after TAVR, often, there'll be patients who've been attempted access outside and then present sort of, because unable to access. Is there a role of CT there to look at the valve, commissural tab, interaction, etc., to decide? Or would you just go ahead with another attempt?
Not really. It's hard to plan the coronary access from the CT. You can't really see the stent, the opening of the stent frames well enough to do that. And in fact, there may be if you did a CT overlay on your fluoro images, but we don't have, it's a capability we're working on. It should be in our new hybrid room, but we don't have that now. So without sort of that overlay, while you might be able to say, okay, I should come through this stent strut, when you're looking at it under fluoro, you're not going to be able to tell which stent strut that was that you were looking at on CT.
Hey, John.
Hey, Costin.
when you look at these patients, again, I always struggle with how do you decide symptoms coronary versus the, you know, the AS? When it's severe AS and you see a, let's say a mid LAD that's tight, how do you go about saying, you know, should I do this because he has symptoms from the coronaries or it's, you know, the AS?
Yeah, so I think it's really a case by case basis. So, and it also depends a lot on the risks of the procedure, right? So if you have a, you know, 70% circumferential, heavily calcified mid LAD in a 85-year-old with, you know, heart failure, no angina, and you know, really severe aortic stenosis, it's going to be a complex PCI, roto, a lot of risks. It's probably one that I would leave behind. If on the same hand you have, you know, a similar lesion, but it's very straightforward, it looks like it's nice and soft, there's no plaque there, you're in there, the patient's, you know, maybe even a similar age, maybe angina is part of their symptoms, and it's sort of, you know, it's a prox or a mid LAD or a prox RCA, I probably would go ahead and fix that. A lot depends on sort of on how complex your PCI is going to be. We have had a number of patients actually not make it from the time of their PCI to their TAVR due to complications from their PCI. And often that's when it's a roto or other, you know, complex bifurcation and a distal RCA, which in retrospect, you know, if the patient's not having a lot of angina and their main symptoms are heart failure and it's really bad aortic stenosis, you know, they can get through their TAVR with coronary disease. It's very different than trying to get them through bypass in a surgical procedure.
Got it. Got it. So basically you incorporate symptoms, but also lesion, specific lesion characteristic in your decision. And you don't see a lot, basically, you don't see a lot of MIs in your TAVR patients with,
No.
right? Perfect. Yeah. Thank you.
Yeah, I mean, you know,
really helpful.
obviously, you know, it's a 90% distal left main that's heavily calcified. That's a different story, right? But, and there, you know, you've got to talk about this stuff. No, and we don't see MIs frequently at all with our TAVRs.
Perfect. Thank you.
All right, I don't see any other questions or raised hands or comments in the chat box. So maybe we'll give 10 minutes back to everybody. Thank you so much, John. That was a wonderful talk. There's a Jack article about coronary access after TAVR. If you would recommend that, I can send that out to
It's a good article. I would go ahead.
Review.
Yep.
All right, sounds good.